Hello, my name is Leo. I'm an intensive care doctor working in the UK. Hope you're well. In this video, I would like to discuss how to support patients' ventilation on intensive care unit. Basically, we can assist patients' respiration via natural airway and artificial airway. Some patients who are admitted to ICU for other organ support may not need any ventilatory support. In such patients, we should keep them on room air. Without providing any supplemental oxygen could be a way to support and maintain a patient's oxygen saturation in a suitable range, for example, 88 to 92% in patients with chronic type 2 respiratory failure like COPD. If a patient becomes hypoxemic and requires supplemental oxygen, we can oxygenate the patient by nasal cannula for low flow or high flow oxygen, face mask with or without reservoir bag, also called non-rebreather, venturi mask, or face mask with water circuit, also known as Mapleson circuit. Next, we can non-invasively ventilate patients via continuous positive airway pressure CPAP or bilevel positive airway pressure BiPAP in patients with severe type 1 or type 2 respiratory failure. If the respiratory failure is not reversible with these types of support, we should consider ventilating patients through artificial airway, if appropriate, via invasive techniques such as endotracheal intubation and positive pressure ventilation. We can consider tracheostomy in patients who are struggling to be liberated from mechanical ventilator, and cricothyroidotomy in patients with difficult airway during emergencies. In advanced respiratory centers, we can provide extracorporeal carbon dioxide removal or extracorporeal membrane oxygenation via sophisticated equipment in patients with very severe respiratory failure, which is not responding to routine invasive ventilation, should they meet the criteria for ECMO. I'll discuss in details about all these in other videos. We can also improve the patient's respiratory mechanics by inserting a chest drain in severe pneumothorax or massive pleural effusion, or by proning the patients with severe ARDS. Chest physiotherapy is essential for pulmonary rehabilitation in patients, especially when they have high secretion loads and frequent mucus plugging. It could be very helpful when combined with flexible bronchoscopy. From medication perspective, we can use bronchodilators such as salbutamol and ipratropium bromide via nebulizers, aminoflame, magnesium, ketamine via IV infusion. Mucolytics such as saline nebulizers and carbocysteine, or some reversal agents, for instance naloxone for opioid overdose and flumazenil for benzodiazepine overdose. We can also give nitric oxide inhalation and prostaglandin-like epoprostenol nebulizers to patients with severe pulmonary hypertension due to ARDS. If a patient is having massive PE, we can consider therapeutic anticoagulation by subcutaneous heparin or IV heparin infusion with or without thrombolysis. These are the respiratory supports that we can offer to respiratory failure patients who are not manageable on the wards. Thank you for watching. Hope this video is useful to you. If it is, please share it with your friends and colleagues. I'll see you in the next video. Take care.